And welcome everyone to our first Navigating Cancer webinar. And these webinars were put together by the Community Advisory Board of Mount Sinai. And if anyone is interested in finding out more about the Community Advisory Board, I think we'll put the information in the chat. Does everyone see the chat, or does just the panelists see the chat? But somehow we will find you and get you the information to the Community Advisory Board if you would like to be part of it. And we decided to start our Navigating Cancer series with multiple myeloma because March happens to be Multiple Myeloma Awareness Month, and we have a wonderful myeloma department at Mount Sinai. So today we will be hearing from three of the panelists, or three of our faculty members: Dr. Santiago Thibaud, or Thibaud, like the football player, I was told, Dr. Joshua Richter, and Yumi Sung, who is one of the social workers here. And I guess, you know what, I will probably forget to read everyone's bio unless I read them all at once, because I get forgetful at times. So let me tell you a little about them before we start our webinar. And Dr. Santiago Thibaud is a native Argentinian, and he received his medical degree from the Instituto University. They're trying to test my Spanish here. It's just not working. In Buenos Aires, he graduated at the top of his class. He completed his internal medicine residency at Albert Einstein College at School of Medicine, where he was the chief resident. He recently completed his fellowship training in hematology and medical oncology at the Icahn School of Medicine at Mount Sinai, and he was appointed as a chief fellow. Dr. Thibaud joined the Multiple Myeloma Center of Excellence at the Icahn School of Medicine at Mount Sinai as assistant professor in 2022. His academic interests center on improving the characterization of genomic landscape of multiple myeloma affecting the marginalized populations, with the aim of leveraging this knowledge to guide the design of investigator-initiated clinical trials and other translational research studies that will address unmet needs in this population. Welcome, Dr. Thibaud. Next up would be Dr. Joshua Richter, who is an assistant professor of medicine, hematology, and oncology in the myeloma division at the Tisch Institute of Cancer at the Icahn School of Medicine at Mount Sinai, and the director of myeloma at the Blavanic Family Chelsea Medical Center at Mount Sinai. They're giving me all these things, and there's many words here. He completed undergraduate work at Johns Hopkins University and subsequently went to medical school at the New York Medical College, where he completed residency at St. Vincent's Hospital. Dr. Richter completed his hematology oncology fellowship at Yale Cancer Center. After completing his fellowship, he worked in the myeloma division of the John Theuer Cancer Center at Hackensack University Medical Center. And in 2018, he joined the myeloma division at Mount Sinai Hospital. Dr. Richter has published in numerous oncology journals, including the New England Journal of Medicine, Blood, and the Journal of Clinical Oncology. He has an interest in immunotherapy, multifunctional antibodies, and precision medicine. Welcome, Dr. Richter. And finally, we have Yumi Sung, who is the social work program coordinator at the Center of Excellence of Multiple Myeloma at Mount Sinai Hospital. Since joining in 2010, Yumi has been instrumental in developing psychosocial programs to meet the emotional needs of patients affected by multiple myeloma, as well as their caregivers. She leads a team of 5 social workers providing continuity of care for myeloma patients that begins at diagnosis and continues throughout the entire trajectory of their journey. And a little bit about me, I'm Cindy Chmielewski. I've been living with myeloma since 2008, and I am a research advocate in the myeloma community. So you got to know who we are, and I think we're going to start our program with Dr. Thibaud talking about management of multiple myeloma. And if you have any questions for any of the panelists, at the bottom of your screen, there's a Q&A button, a question and answer button. You could write your questions in there. And at the end of the program, we will answer as many questions as we can, as long as time permits. And the only heads up I give you is try to make your questions as general as possible and not specific to your situation. So let's start off with Dr. Thibaud talking a little bit about the management of multiple myeloma.
Thank you so much, Cindy, for the introduction. Good morning, everyone. It's my pleasure to be with you here today to share some information about myeloma. I'd like to start with a little brag. We have international viewership today. My dad is a multiple myeloma patient, and he is actually joining us from Uruguay, where he lives. He's a little camera shy, so I won't ask him to turn his camera on. I don't even know if he can because it's a webinar, but I'm glad he was able to join. So let's get right to it. Slide, please. Here is an outline of my talk. First, we're going to talk about what multiple myeloma is, give a brief overview. Then we're going to talk about who needs to be treated. And finally, we will cover what treatments are currently approved by the FDA for use in myeloma, including for patients who are newly diagnosed with a condition and for those who have relapsed. Next, please. Okay, so what is multiple myeloma? The story starts in the bone marrow. The bone marrow is a factory, slide please, where all of the blood cells are made. We have our red cells that help carry oxygen, our platelets that help with clotting of the blood, and our white cells, which help us fight infections. Next, please. There are many different kinds of white blood cells, but I'm going to focus today on a particular one called a plasma cell, depicted in green here. These cells protect us against infection by making antibodies, which are proteins. In the course of someone's lifetime, one of these cells can suffer mutations in its DNA, and as a result can become abnormal, can stop responding to the checks and balances the body has in place to prevent cells from functioning autonomously or independently. And so this rebellious cell is able to grow and replicate, creating clones of itself. That's why we call it monoclonal. And instead of making normal healthy antibodies, these abnormal plasma cell clones will now make an abnormal protein, which looks like an antibody, but has none of its function. It does not protect us against infection. Okay, so let's say this change has occurred and this population of abnormal plasma cells now exists in someone's body. This in itself is actually a fairly common thing that can happen to people, and it doesn't always require treatment. So the question is, of course, when is this a problem? When does it require an intervention? We'll explore two different scenarios. In the first, we have a small number of abnormal plasma cells, which are producing a small amount of abnormal protein. And what's more important, neither the cells nor the protein they are making are causing any trouble. The patient has no symptoms. This is a condition I bet many of you have heard of, which has a complicated name, but we refer to it using an acronym, monoclonal gammopathy of uncertain significance, or MGUS, or MGUS. As I mentioned, MGUS is actually a pretty common condition. I always say that if I were to walk out to the street and grab 100 people randomly and test them all for this condition, I would probably pick up on 5 or 6 who have it. And the truth is, most patients with MGUS will remain asymptomatic for a long, long time, often for their whole lives. So they don't require treatment. They do, however, require periodic monitoring to make sure they don't develop symptoms over time. And that is scenario number 2, where these cells have become more numerous. They are now taking up a lot more space in the bone marrow and preventing other healthy cells from doing their jobs properly. And these cells can start making larger amounts of abnormal protein. And in this scenario, the patient will typically develop symptoms. So what symptoms are we talking about? We have a helpful mnemonic that we use, and that is CRAB. C stands for high calcium. R stands for renal or kidney problems. A stands for anemia or low red blood cells. And B stands for bone lesions, which are often painful. We can no longer say that this is MGUS since the patient has symptoms. The patient now has multiple myeloma, which is a type of cancer of the bone marrow and the blood, and it requires treatment. Slide, please. This slide shows a summary of all the different treatments that are available to treat cancer in general. But of course, each type of cancer is different, and some treatments may be helpful for one type but not for other. So let's go over them one by one. Surgery is not something we use to control myeloma. Why? Because surgery typically helps when there is a localized cancer that can be removed in its entirety. But myeloma is a cancer of the blood, and blood is everywhere. So this is not a localized cancer. How about hormonal therapy? We use it to treat breast cancer, for example, not helpful in myeloma. Radiation therapy is something that we often, slide please, often use in myeloma patients, but not with a purpose of controlling the growth of the cancer. We use it to target specific lesions in the bones that may be causing pain. As I mentioned before, if the cancer affects the whole body, we can't radiate the whole body, and radiating a single spot or a few spots won't help control the growth of the cancer. The treatments that are helpful in myeloma, which we'll talk about in the next few slides, are chemotherapy, immunotherapy, and bone marrow transplant. And I'll add that we are also developing targeted drugs, which do not necessarily qualify as chemo or immunotherapy. These are becoming increasingly available in many cancer types, including myeloma. So what drugs are available to treat myeloma? Many. We are lucky because this is a very treatable form of cancer. It wasn't always the case, but in the last few decades, there have been massive advancements in the field, and we now have a wide variety of treatments available. In the interest of time, I won't be going over each of these drugs, but I will take the opportunity to say that as a general principle, myeloma is almost always treated with combination therapies. Slide, please. We need the synergy of several of these treatments working together to effectively fight the cancer. This slide just summarizes the various ways in which we can administer myeloma treatments. Let's go back to the previous slide, please. Many of these drugs are given by mouth, whereas others are given intravenously or subcutaneously. Next slide, please. Now, let's talk about the typical structure of the treatment plan for a patient who has a new diagnosis of myeloma. As I mentioned previously, we sometimes treat myeloma patients with a bone marrow transplant. We also call it an autologous stem cell transplant. This is a highly effective approach, but it is not for everyone. Why? Because part of this intervention involves the use of high-intensity chemotherapy, which will hit the myeloma cells like a sledgehammer, but it will also wipe out the entire healthy bone marrow of a patient. And that's why we need to give the patient back stem cells so that they can grow back the healthy bone marrow. And in some patients, such as those who are very frail or elderly or have other serious medical conditions, this approach may be too risky. But let's talk about what the treatment looks like for someone who we determined is transplant eligible, meaning we think they'll be able to tolerate intensive chemotherapy. These patients will start out by receiving an induction phase, which typically lasts 4 to 6 months, and it involves the use of 3 to 4 drug combinations. Next slide, please. Then we will pause treatment and do what we call a stem cell harvest. We basically give some shots to squeeze out stem cells out of the bone marrow where they live, and into the bloodstream so that we can harvest them and or collect them. Next, please. Then we decide if we decide to proceed with the stem cell transplant, we will have the patient be admitted to the hospital where we will give the intensive chemotherapy and then give them back the stem cells we collected so that they can grow back the bone marrow. Patients typically end up staying in the hospital for about 2 to 3 weeks. Then sometimes we will give a consolidation phase in which we go back to the 3 or 4 drug combinations that they were previously receiving for a few more cycles. But I will say that this is not typically the case. Next, please. We definitely want to follow the transplant with a maintenance phase in which we give 1 or sometimes 2 drugs for a long period of time to keep the myeloma in remission. How long? There's a lot of debate in the field, but most would say that at the very least, we should treat for 2 to 3 years. And many would say that patients should be treated indefinitely or until the cancer progresses. Next, please. How about patients for whom transplant is not an option or who choose not to undergo the stem cell transplant? These patients will still receive an induction phase in which we treat with 3 to 4 drugs for 8 to 12 months, so a little longer. These drugs are typically the same drugs we use for induction in patients who will be undergoing a transplant. Next, please. Now, I include this as a second step because even if we don't plan to proceed with a stem cell transplant, we should always consider doing the stem cell harvest. These stem cells that we collect can be frozen and stored for several decades. So if things change over time, we will have them available for use. And then again, we follow the induction with a maintenance phase using 1 to 2 drugs, essentially until the cancer progresses. Next, please. Okay, so now let's talk about patients who have a relapse of their disease. As you can see here in this figure on the left, we start out at the time of diagnosis with high levels of abnormal proteins. Then we treat and we get the patient into our remission. And then at some point, the disease comes back with rising levels of abnormal proteins. And this relapse requires a change in therapy to bring the numbers back down. Next, please. What is the structure of a treatment plan for a relapse patient? Well, it's complicated. There are so many different options, different drug combinations we can use. And this is when consulting with a doctor at a cancer center where physicians specialize in treating myeloma, such as Mount Sinai, becomes important. Because at this stage, the approach has to be individualized to fit the patient's specific characteristics and needs. Again, in the interest of time, I won't go over each of the possible combinations we use to treat relapse patients. It would take the whole day, but I do want to bring up 2 of our most novel therapies in myeloma, which are really groundbreaking in the field and extremely promising effective therapies. First, I'll briefly explain what CAR T-cell therapy is. You probably have heard of it. In a nutshell, if you can follow the cycle shown here with me, we first collect the patient's blood. We extract the T cells, which are a type of white blood cell. We modify those T cells and train them to recognize and attack myeloma cells. And then we infuse them back to the patient where they can go and fight the cancer. There are currently 2 FDA-approved CAR T-cell therapies for myeloma patients, ide-cel and cilta-cel, and many more in development. And then the second novel therapy is bispecific antibodies. In this case, we give patients an antibody that was engineered in the lab to attach to 2 different markers in 2 different cells. One is the myeloma cell, and one is the T cell. So now these cells have been brought together by the antibody. The T cell can say, hey, you don't belong here, and attack the myeloma cell. So again, very exciting developments in this area. And in fact, only a few months ago, one of these drugs called teclistamab became FDA approved for use in relapse patients. So that's the end of my talk for today. I'd like to give a shout out to all of the amazing myeloma specialists here at Sinai. It's really an honor to be a part of the stellar team. And also a big thank you to the Health Tree Foundation for all the incredible work that they do in supporting our patients and for sponsoring this event today. Thank you.
Yeah, thank you so much, Dr. Thibaud. It was a wonderful overview. I do have some questions I could ask you at the end, but I'm just reminding anyone who's watching, any of the people who are on the webinar, if you would like to ask some questions, you can put them in the question and answer section, and we will get to them at the end. And now we're going to have Dr. Richter talking to us a little bit about clinical trials. What are they and why it's so important to ask about them? Dr. Richter, you're on.
Awesome sauce. Hi, welcome everyone to this wonderful collaboration between Health Tree and Mount Sinai. I'm going to talk about clinical trials and hopefully demystify a little bit of this because clinical trials can be a very scary concept. Next slide, please. So when we're talking about clinical trials, for all intents and purposes, there are 4 phases. There are some actually middle ones like 1A, 2B, all this stuff, but think about it in terms of 4 phases. Phase 1 clinical trials are saying we have a brand new drug, we're going to test it, we've tested it extensively in the lab, in other animals, and now we're ready to test it in human beings. And the whole concept of a phase 1 trial is to make sure that this drug is safe to give to human beings. And although there's a lot of differences, most phase 1 trials work like this. You give 1 milligram of the drug to 3 people. As long as it's safe and they're not major complications, you give a higher dose, say 5 milligrams to 3 more people. As long as it's safe, you go up to 10 and so on, and you try to figure out what the right dose is. We're not actually very much focused on exactly how well the drug works. It's really more to make sure that this is safe to give to people. Usually in myeloma, this is around 10 to 50 patients. Once we know what dose to use, we move on to phase 2. Phase 2 is saying, well, now that we have an idea of the dose, let's give it to more people and let's get a real good idea of not just how tolerable it is, but how efficacious it is. And this can be up to around 100 patients. Now, once we're ready and we know a lot more about the drug at this point, we're ready to go on to phase 3, which is typically phase 3 is what the FDA usually looks at to approve a drug. The FDA can approve drugs based on phase 2 studies, and it has. The CAR T cell therapies and bispecifics were approved on phase 2 studies. But oftentimes we need phase 3, and phase 3 studies take whatever you're doing and compare it against whatever the standard is at that point in time to see if it's as good or better. And we'll talk about that in the next slide. And phase 4 studies actually exist because they say, well, once the drug is approved, can we learn more about the drug in select groups of people or long-term evaluations? And these are post-marketing or post-approval studies, which can involve thousands of patients. Next slide, please. Now, I think one of the biggest concerns or questions that I hear when talking to patients about clinical trials is, am I going to get a placebo? For phase 1 and phase 2 studies, there are no placebos because we're just giving everyone the drug. And actually for phase 3 studies, it's rare nowadays to get a placebo because there was a number of major laws passed that basically say you cannot knowingly give people an inferior form of treatment. If there is a standard of care, you must at a baseline, as a comparator, give that standard of care. You can't give a placebo. So you can only give a placebo if there's absolutely no drugs in a space, no standard of care, and you have a new drug, you can compare that versus placebo. In myeloma, the only remaining placebo studies that are done are when we compare drug A versus drug B with or without drug A. So it could be one drug versus another, and then you can have that drug with a placebo or with the other drug. So at a bare minimum, you're getting some therapy. So it's always important to ask, but very rarely are we giving placebos in myeloma studies. Next slide, please. I wanted to throw out a list of questions that you can ask if you're talking to your care team, be it at Mount Sinai or anywhere else, to talk about clinical trials. First of all, just asking, If any of your care team says, here's our treatment, ask, is there a clinical trial available for me? Maybe there is, maybe there isn't. And if there is, how does that clinical trial differ from the standard of care? If you decide not to participate in a trial, let's say your care team says the next best step is a trial, you can ask, what are the alternatives? What else can I do besides that? You should ask, what phase is it in? Is it in phase 1, 2, or 3? Because if it's phase 1, your team may not know much about how good or bad the drug is just yet, but the science behind it may say this ought to work very well. If it's phase 3, they may say, oh, we've treated 100 patients and we know this. How long does the trial last? Trials last different amounts of time. What if you change your mind during the trial? In order to move forward with any trial, you need 3 groups to say yes. The patient needs to say yes, the care team needs to say yes, and whoever is sponsoring the trial needs to say yes. At any time during the trial, if any one of those says no, it stops. You can literally have the drug about to go into your arm and you can say, you know what, I changed my mind, I don't want it, and you have the power to do that at any time. We all are concerned about finances. What costs are covered by the trial? What costs are not covered by the trial? And are any ways to offset that? And always important because, for example, at Mount Sinai, we have multiple sites. You may want to say, can some of the clinical trial tests, procedures, or labs be done at other places? Let's say you live in Long Island or Connecticut or New Jersey, and you're coming in for a trial. Is there any way that you can get blood work locally in between so you don't have to make that frequent visit? Next slide, please. So I'm going to talk a little bit more about some of the new drugs that Dr. Thibaud talked about, because in general in myeloma, we have 3 big categories of trials that are the most prominent right now: bispecific antibodies, CAR T-cell therapies, and precision medicine or targeted approaches. So bispecific antibodies, and I put some images here, and hopefully someone is old enough as me to recognize this. This is from the original Mad Max, starring the amazing Tina Turner. And for those of you who remember the Thunderdome, the motto of the Thunderdome was 2 men enter, 1 man leaves. And that's exactly what a bispecific antibody is. A bispecific antibody has 2 arms. It grabs on, one arm grabs onto the myeloma cell, the other arm grabs onto your T cells, which are part of your immune system, and get them to attack the myeloma. And I think about this as myeloma Thunderdome. Your myeloma cell and a T cell enters, the T cell destroys, and only the T cell leaves. Those are one of the great trials that we have going on in myeloma. We have many of them. Next slide, please. These drugs are off the shelf, which means they can just be infused at any time. They don't need to be manufactured. But right now, here are the main candidates. And these are not only the only ones we have. These are just a small snippet. Now, in bispecific antibodies, right now, that drug that the part of the arm that attaches to the T cell is called CD3. CD3 is on all T cells. The arm that attaches to the cancer cell, we have multiple options. All the ones on the left, that other arm attaches to something called BCMA, B cell maturation antigen. That's on all myeloma cells. So basically, all those drugs with the crazy names, alnuctamab, elranatamab, linvoseltamab, this all has CD3 attaches to the T cell, BCMA that grabs onto the cancer cell, 2 men enter, 1 man leaves. But we have newer targets as well, and all the ones on the right still have that CD3, but grab onto a different part of the myeloma cell. The first one on the right, called talquetamab, grabs onto this crazy thing called GPRC5D. And forget all that nonsense. This is an amazing new drug that was filed to the FDA about a month and a half ago, and we're anticipating its approval later on this year. The next drug, called cevostamab, grabs onto yet another part of the myeloma cell called FcRH5. FcRH5 is also on all myeloma cells. This drug's a little farther away, probably 2024 or 2025, before we get it in the clinic. Next slide, please. All right, so CAR T cells. Ooh, is this my slide? I guess. All right, so I'm copying Dr. Thibaud. I apologize. We're digging through the same slide deck. But basically, I think you already kind of went through how CAR T cells work. We collect your cells much like we collect them for transplant. Fancy people like Dr. Thibaud and Dr. Parikh manipulate them in the lab to all attack the myeloma. Basically, engineer your T cells to all attack that BCMA, and then we put them back into your body. Next slide, please. How CAR T cell works. Sorry, this is my slide. This is a cool animation I stole from Craig Cole, who makes the best slides. So we engineer those T cells. They all are going to attack BCMA. It grabs onto the cancer cell and it basically kills them through a variety of mechanisms, because now all of those T cells are targeting the cancer cell. Normally, T cells target bacteria, viruses, fungus, your next door neighbor, anything. But here, they're just going to attack the myeloma. Next slide, please. There are a number of amazing research studies being done, clinical trials in CAR Ts. So as Dr. Thibaud pointed out, we already have 2 FDA-approved CAR T cell therapies in myeloma, cilta-cel and ide-cel, also known as Carvykti and Abecma. And there are many CAR Ts approved in other cancers like leukemia and lymphoma, but we're always trying to do better. How are we trying to do better? Well, here on the left, we see the 2 that are approved. There's a couple that are using alternate manufacturing, even things like rapid production. Right now, that manufacturing of the T cells takes 4 to 8 weeks, but there is a newer version that takes 24 to 36 hours to manufacture. How amazing would that be, instead of having to wait a month or 2 to get it much sooner? What if it didn't even have to wait that long? The allo CAR, these are donor-based CAR T cells. Theoretically, you don't have to wait any time. You can have them stored at your site. And then so far, the 2 approved CAR T cells target that BCMA. What if we start looking at other targets? And we're doing that trial here and is being done at many other institutions, grabbing onto other targets on the myeloma cell like GPRC5D. And even crazier, we have some CAR Ts that are grabbing onto 2 sites. So a lot of great clinical trials currently going on. Next slide, please. Now, a lot of us on the trial have heard about drugs like Revlimid and pomalidomide, and even thalidomide, because they're all derivatives of that drug, thalidomide. There are a new generation of these drugs. So we call drugs like Revlimid and pomalidomide IMiDs, or immunomodulatory drugs. The next class of agents, the new Revlimid is called iberdomide, and the new pomalidomide, it goes here by the name CC92480, goes by the name mezigdomide. Or if you want to be cool, the cool kids are calling them Iber and Mezi for short. They're really just new IMiDs. They're more potent, more effective versions. So just like pomalidomide can work when Revlimid stops working, iberdomide or Iber can work when pomalidomide stops working, and you can even have mezigdomide. These 2 drugs are likely to be approved in around 2025. The first approval for iberdomide will be in combination. It'll be iberdomide Velcade index and iberdomide daratumumab index. And mezigdomide will probably be about 9 to 12 months after that, Kyprolis mezigdomide index. Next slide, please. And by the way, those are all pills that you'd get from the same, you do the survey once a month, same concept. And in the last 2 slides, what are we looking at? We're trying to target myeloma. Dr. Thibaud amazingly pointed out, we have so many great drugs, but how do we choose them in an individual? We don't have any great plan a lot of the time, except to say we know up front we combine these are 3 or 4 drugs. They work really great in a lot of people, if not anyone, if not everyone. And we can combine these drugs and then these drugs. But the whole idea is your myeloma is different than somebody else's. Myeloma is thousands of diseases. What if we can identify what makes your myeloma go forward and not just give generally good drugs, but drugs specifically targeted to you? And we know that there are a number of what we call actionable mutations. There are genetic abnormalities, not that you inherit, but inside your cancer cells that make myeloma go forward that have drugs approved in other cancers. Next slide, please. So what the MMRF has done, and many sites are working on this, including us, is we sequence your myeloma and we give you a backbone of myeloma therapy, a drug like ixazomib, pomalidomide, and dexamethasone, but we add on a 4th drug that's a drug that's already approved in another cancer that targets a genetic abnormality that we may see in lung cancer, but also in myeloma, in GI cancer, but also in myeloma, in melanoma, but also in myeloma. So you see here this list of another list of crazy names like cobimetinib, endalucimab, abemaciclib, erdafitinib. Erdafitinib is a drug that's used in bladder cancer for people who have this activating mutation in FGFR3, and it treats those patients great. Guess what? Some myeloma patients have the same genetic abnormality, so we're starting to incorporate that into those patients as well. So a lot of great options on the horizon, both from a broad-based standpoint of just efficacious in lots and lots of people, to boiling down and making a targeted approach for everyone. So I strongly encourage you to ask about clinical trials, get involved in clinical trials, recognize that it's not just using people as guinea pigs. It's really working together as a community to work towards the cure. Next slide, please. And with that, I will say thank you for listening and turn it over to our next great speaker.
What a wonderful presentation. I have lots of questions here, and I see lots of questions coming in. We're not forgetting about your questions. We're going to get through all the speakers first, and then I'll start asking some of the questions that are coming in. And remember, at any time you could type a question into the question and answer box at the bottom of the screen. And our final speaker is Yumi Song, and she's going to talk about some of the supportive care services here at Mount Sinai.
Thank you, Cindy. Thanks for having this webinar. It's such an honor to be on a panel with Dr. Thibaud and Dr. Richter, whom I have the great privilege of working with. And I'm used to saying I work with 10 myeloma specialists, but until Dr. Thibaud flashed a slide of all the attendings, I just realized that we were losing one of the original physicians who started the program here in 2010. So we are, next slide, we're a group of 5 at the main hospital, and we collaborate closely with our other social work colleagues at Chelsea and Brooklyn. Next slide. We know that each person has their own unique challenges when faced with myeloma. And we hear you and we hear your concerns and needs when you say, why me? I can't afford these medications that Dr. Thibaud and Richter just outlined. How do I tell my family and children? How will I get to the cancer center 3 times a week? Or miss work for 3 months or 2 weeks? I'll lose my health insurance if I don't work. Why do I need all these tests and scans? And why so many different types of treatments? So we hear your concerns. And so I'm going to take the next few moments to go over some of the support resources that are available to address these emotional and practical needs. Next slide. Want to first stress the importance of maintaining your emotional well-being. Feeling overwhelmed and distressed when diagnosed and facing treatments are normal. There are resources available to help you cope. Many cancer centers now have psychiatrists as well as psychologists, along with social workers and spiritual care available to you. But think about what is the best mode of support that you prefer. Some like group settings where you can connect with others going through the same type of experience, and or you may prefer one-on-one. If you are under the care of a psychiatrist, and especially if they're prescribing medication to help with your mood, please let your oncologist know. We may need to collaborate with them in the future. Peer-to-peer support is also available if you want to just talk to another myeloma patient. Just be careful when you're comparing notes that not everyone has the same experiences and outcomes. And maintaining a healthy lifestyle, healthy diet, exercise, sleeping well. When you get a good night's sleep, you feel better. It's a good cycle to maintain. And social connection. We know that having social connection, that's why support groups are great, and relating to others reduces feelings of anxiety and distress. Next slide. At Mount Sinai, we have several support groups to cater to our diverse population and their needs. These are some that are currently being facilitated by our oncology social workers. There is a link to the support and wellness newsletter that is updated monthly and lists all of the support services at our cancer center. If you are not accessing care at Mount Sinai and are at another cancer center, ask your social worker or your care team about the available resources there. Next slide. And there are many community agencies that provide counseling and support groups and peer-to-peer support. So check them out. They're mentors. Patient navigators also can help direct you to the right support or resource if you're starting at a place that's not appropriate for you. If you are feeling depressed, speak with your doctor, speak with your mental health professional. Some areas have a 24/7 hotline available. Next. And knowledge is power, right, Cindy, as a teacher? Understanding your myeloma, attending seminars or webinars like you are now, and understanding all aspects of your care can be very empowering, reducing anxiety about the unknown. But make sure you get your information from a reliable source. Dr. Google has a lot to say about a lot of different things. So just want to mention a few sources. They're great places to start. International Myeloma Foundation provides information in multiple languages. And if you are undergoing transplant or CAR T, there are specific organizations that provide support specific for that treatment. Next. I wish there was a time when there would come a time when I did not have to talk about the next two slides, and when insurance and the cost of treatment is not a barrier to accessing clinical trials that Dr. Richter mentioned, or the initial therapies that Dr. Thibaud mentioned. But as you know, it's so important to maintain your health insurance coverage. If your insurance is provided by your employer, find out what your benefits are. See if you have medical leave or disability insurance. And if you're thinking about changing insurances, speak to your provider, speak to your social worker and your financial coordinator. If your doctor advises you that you need to stop working because of your condition or treatment regimen, you may need to consider permanent disability. You may need to call Social Security to initiate your disability process. It's just important to not have a gap in your coverage, especially if you're in the middle of treatment. Medicare, Medicaid coverage through the marketplace or COBRA are some plans that you may consider when you leave your employer. Excuse me. Cancer and careers, great resource if you're working through your cancer and your treatments, or you're thinking about returning to your work. Triage Cancer and Cancer Advocacy Project provide cancer-specific legal issue assistance if you feel like you're being discriminated against or have issues with your insurance coverage for your care. They also assist with legal documents of estate planning or like power of attorney and things like that. Next. And even with adequate insurance coverage, co-payments, high insurance premiums are always an issue, and it's a huge financial burden and added stress to our patients. This is a list of organizations we often use for copay assistance. I know a lot of them are currently closed. They open and close throughout the year, so check frequently and apply as soon as you're able. Check with your state to see if they have prescription coverage for seniors or disabled. Needed Meds, I want to mention because it's a great website, or you can call them, but you can literally put in the name of your drugs, like Revlimid, and it will pull up patient assistance for copays through the drug manufacturer, BMS, or the above mentioned organizations. Lazarex is a great well, just go back. Resource if you're enrolled in a clinical trial is, okay, you can, next slide. So getting to the cancer center, even if you're coming from Long Island or Staten Island or into Brooklyn can be costly. Tolls, parking, cab fare. Some insurance plans cover transportation, so check with that. You may want to consider paratransit services. We have many, many patients coming from out of state to access specialized myeloma care at our center. So I have patients flying in via Angel Flight or Corporate Angel. They stay for free at American Cancer Society's free Hope Lodge for the duration of their treatment, and then go back the same way. Some pharmaceutical companies now offer travel lodging assistance, especially like CAR-T and the bispecifics that Dr. Richter mentioned, treatments that involve complicated multiple visits, long stays. So that's a great resource. Next. And some others, because some other resources depending on your needs. We know everyone's needs are different. Just want you to know that there are support resources available at your cancer center in the community. If you have difficulty or need assistance in accessing them, please speak with your care team. You're not alone in this journey. Thank you.
Well, thank you. There were so many resources there, so I can't keep track of them all. So I guess the important thing is if you have some need, or even if you don't have a need, maybe just request an appointment with the social worker. The social worker can help you. And is that the way people go around? Do they request an appointment with the social worker? Does the social worker find them? How did the two of you connect? I mean, can you explain that a little bit?
I mean, we have a great team. We have, we get referrals from Dr. Richter and Dr. Thibaud, and team of nurse practitioners and nurses and infusion nurses. So some of the comments that I mentioned in the beginning, if they hear things like, I can't get here tomorrow for my appointment, or I can't afford this medication, they will call us. There are initiatives where we, are trying to meet with the patients at their C1D1 visit, their cycle 1, dose 1, their first treatment visit, or if they're newly diagnosed. Yes.
So that's good. And always a patient can request. Is that correct? Like if a patient
Absolutely. Absolutely.
Okay. And there was one thing that came to mind that I found was a really wonderful resource. There's an organization, a website that's called fundfinder.org. And if you create an account on fundfinder.org, then you could put in multiple myeloma and you will see all the funds that are opened and all the funds that are closed. And when a closed fund becomes opened, they will send you an email. So I think that is a very valuable resource for instead having to check every single website. So now let's get to some of the questions. We've learned so much, and let's go. The first question is probably one of the $1 million questions. It's a question that I hear over and over again, and maybe we'll have the two doctors give us their perspective. With our great induction therapies, many times we get into great remission. Some of us get to MRD negative, no evidence of disease. Is there still a need for transplant if your disease is so low and non-detectable? And just your thoughts on it. Dr. Thibaud, since you started talking about induction therapy, I'll let you go first.
Thank you. Excellent question. And it's, I must say that it is very much debated in the field at the moment, right? So it used to be that transplant was essentially the only highly effective tool that we had against myeloma, and now we've come so far since then. So, you know, is transplant still the standard of care? Is that what we should be doing in every patient that we that we think would tolerate it? And I think I'm gonna cite Dr. Richter here, and you know, if you ask 10 myeloma doctors what you should do, you're going to get 10 different answers, because you know it's complicated. There's so many variables to consider. So I think, you know, it is certainly in my practice, what I do is I tend to favor doing the transplant as part of the first line therapy, even if someone has achieved a great remission with their induction. But I'm very open to having a conversation with patients, and I make it clear that there is some flexibility in those settings, right? There may not be in every case. Sometimes we really need the transplant, but when we're not doing it for, you know, when we have that flexibility, I offer it to patients to make up their mind as to whether they would rather delay the transplant. There is some data that doing the transplant early on is better than doing it later in the game, right? That's in a nutshell what I would say, and I'll let Dr. Richter give his thoughts.
Yeah, I gave you a very hard question to begin with. Dr. Richter, want to add anything to that?
No, I think we have limited time for questions, and I agree with everything that Dr. Thibaud said.
Sounds good. Okay, and another question is, suppose a patient who's a patient at Mount Sinai needs a clinical trial, but maybe their case doesn't match any of the clinical trials at Mount Sinai, and there might be a clinical trial at another cancer institution that might fit them better. How does that work? Like, does Mount Sinai help facilitate that? Does the patient have to go on their own? Can you talk a little bit about that scenario?
Sure. So, this is a medicine and myeloma specifically. It's a team sport. It's not one person doing anything. We all work together, not just within the Mount Sinai community, but within the myeloma community at large. I'll give you a great example. I got an email last night from a colleague at Dana-Farber, which is one of the cancer centers in Boston. He has a patient. They don't have a trial. He asked if we have spots on a trial. So one is, if we do know that there's a trial, we can reach out on your behalf. There's a website called clinicaltrials.gov, which lists all of the active clinical trials. So if a patient comes in and says, I'm looking for this trial, it's only available at this site. Do you know anyone? We're happy to reach out for you. It can come across in a number of different ways, but happy to collaborate with other sites if they have something better at that given time.
Great, great. I remember when I was newly diagnosed and I was being treated at one center, and they really didn't have a trial for me, and they sent me to another center, and I felt like I was in that movie, Miracle on 34th Street, when Mr. Macy was sending people to Gimbal because they had a better deal for them. And it just made me smile that my doctor actually thought that I may be able to have a better outcome going somewhere else. So that's nice to hear. Somebody else wants to know, is there a tumor board where complex cases are discussed at Mount Sinai? Either of the docs, tumor boards?
Every Wednesday, we do have a tumor board, which is a collaboration between the myeloma department, the pathology department, the radiology department, so that we can all come together and review all of the nitty-gritty of really tough cases. That being said, that's every Wednesday. If I see a patient on a Thursday and it's a lot more urgent, I will discuss with my other colleagues, of which I have many world-class physicians to reach out to say, what would you do in this case?
Okay, good. Any, let's see, another question here, because we're running short on time, so let's try to get as many questions in as possible. And let's talk about relapse. Whether you're transplant eligible or transplant ineligible, at what point should you change treatment and start a new treatment at relapse? Is there some, is there a magic number? Is like talking about relapse, changing treatment, starting a new treatment? Dr. Thibaud, what would you say? Like,
yes, so what I would say is at the time of relapse, if we have a clear, there may be, when someone is in remission, there may be a period of time when numbers are changing slightly, but we cannot say definitively that that represents a progression of the disease. We have to give it some time. We should never rush to do to make changes, because myeloma is all about, you know, looking at trends, right? Like what's happening with these markers over time. And so I will see that there is a period of time when we have to make sure that there is progression. Now, if we confirm that there is progression, then we do need to change therapies. That is, you know, and how we change therapies, that's where it gets complicated, and it really does depend on a lot of different variables that need to be considered. There's no treatment that's good for everyone. It depends on what side effects they had to, if any, to their initial therapy, whether they are considered to be refractory to the drugs that they received initially or not. So all of those are things that we take into consideration. But yes, as a general concept, a relapse represents a need to change therapy to fight the myeloma in a different way.
Dr. Richter, anything to add?
No, you know, I think he did a phenomenal job. The only thing I would add is that there are specific criteria that are laid out by the International Myeloma Working Group for numbers that constitute progression. You know, if the M spike increases by at least 0.5, if the free light chains increase by 100. But that being said, there's more than just that numbers. And I think exactly as Dr. Thibaud pointed out, you know, the numbers are not all of it. If you go from 0.2 to 0.5 in 10 years, am I going to change it because you hit 0.5? No. So a lot of it is discussing with the patient what's going on at that given time.
Good. And since we're very nearing the end, I think the best question to end with is there any research that's bringing us closer to a cure? So
the answer for that is a resounding yes. In fact, we are currently engaged in a multi-institution approach that is dedicated towards cure. Basically saying, you know, if we look at the treatment that we have upfront in myeloma, newly diagnosed regimens have a response rate of about 100%. But the disease comes back. And some of our great new therapies that Dr. Thibaud spoke about, like CAR Ts and bispecifics, are having amazing responses later on. What happens if we kind of move a lot of that stuff up front and in the right combination? So we're working with a number of different pharmaceutical partners and as well as other academic institutions to provide these big programs of saying, take a newly diagnosed patient, and is there a combination of drugs we use and CAR T and bispecifics to induce a cure? So the short answer is not only are we thinking about it, this is actually underway, and there's a big collaboration as we speak.
Very, very good. Being that research geek, I attend many of the scientific meetings, and about 10 years ago when I started attending those meetings, not once did I hear a doctor saying cure on that stage. It kept on saying we're able to control disease. It could become a chronic condition, but I never heard cure. And more recently, I'm hearing doctors saying we're curing some people. We might not know which ones just yet, but we're curing them, and we have the tools to cure many more. So as a patient, that just makes me, you know, so hopeful. And just hearing that change. And let's see, I have to the questions. Can you email out questions, answers to questions we didn't have time for? Okay, I'm trying to see, we have some questions here that we didn't have time to answer. we will try to figure out what we could do with those. To join us in more with the Navigating Cancer series, and we will figure out how we could get back to people the answers for the questions that we didn't get to today. So I would like to thank everyone and wish everyone a happy Myeloma Awareness Month. Take care. Bye.
Thank you so much.